I'm going to be pausing that right now. Pause. Right here. You're off. Check the clicker.
Oh.
You're good.
Okay.
There will be a critique.
Are we good?
We're
We're
good.
on.
Okay, well, welcome everybody to Harmony Hospice. We're doing a presentation today about dementia with behaviors. My name is Brianna. I'm the CEO and owner of Harmony Hospice. And I have a very special guest here. His name is Anthony Von Diaz. He's the owner of Rosa Shante. And he is celebrating 30 years of being in the community as an assisted living. If you are in the assisted living community, I would say you win a gold star because that is almost unheard of. Not only is he been in assisted living for 30 years, he specializes in dementia with behaviors. So Anthony takes all those folks that nobody else really wants to take. So again, I'm so grateful to know Anthony and to have been mentored by Anthony. So we're excited to share some things that we've learned over the years about dementia and behaviors.
And it's not that no one wants to take them, it's the challenge of being able to care for them, the individual really appropriately.
That is a much better way to explain that. So we got a new clicker. There we go. So dementia and behaviors. So I'm just going to start off with some brief overview. I think, folks in the assisted living world are pretty familiar with this, but really dementia is, I always say, it's an umbrella term. So basically it's discussing all these different specific diseases that have to do with their neurocognitive disorders. So a lot of people say if you have a memory issue, they lump it under dementia because they're not sure what specific disease it is. So we see a lot of frontotemporal dementia. Alzheimer's obviously is what we see the most of. That's the most diagnosed type of dementia. Lewy body dementia, we have Parkinson's who present with dementia. So there's a lot of different types of specific neurocognitive disorders underneath that dementia umbrella. And it's important to know which type of disease that you have because Lewy body dementia presents very differently than Alzheimer's dementia. So the more information you can gather on the specifics of the disease, the better. So stages, and this is from the Alzheimer's Association, which is a fabulous resource. They have tons of handouts, videos, education for caregivers. So we use their literature a lot. But just really briefly, the average lifespan, they say you're diagnosed with Alzheimer's or dementia is 4 to 6 years, which is a little bit scary because a lot of times when we look at these early stages, people aren't really reaching out to get the diagnostic testing, so they don't know necessarily they don't know until they're in the middle or they're in the late stages and it's presenting very clearly. So again, gauging that 4 to 6 years is hard because a lot of primary care physicians aren't good at recognizing Alzheimer's dementia or referring them to a neurologist for specific testing. So the early signs are, coming up. They can't, like I am right now, I can't find my words. You can't find the right word that you want to say, right? So that's something that happens. You forget stuff. You just read something and you've already forgotten, what did I just read? So some things that, again, some of us have just like regularly. So again, it's how do you know when it's a dementia early sign, or it's just normal aging, or you didn't get enough sleep like me. Organizing is one, planning and organizing that we see a lot, and having a difficult time performing tasks. So that's another pretty big red flag. But if you have any suspicion, again, the earlier you can get into the neurologist to get that testing, there are some newer drugs that are coming out that they're never going to cure yet the Alzheimer's, the dementias, but it may slow down the progression. So that early stage is pretty difficult sometimes to see. The middle stage, again, and this is what we're talking about. The middle stage is where we start to see those behaviors come out. So this is where they have a tendency to want to wander. I'm familiar with that. They demonstrate personality and behavioral changes, suspiciousness, delusions, compulsions, repetitive behaviors like hand wringing. We had a lady who would just sit at the table all day long and just shred. And you talk to her and she just couldn't stop. Just shred. So this stage is when you start to see a lot of the behaviors that, again, it's really hard for a caregiver or family member to observe this, because a lot of times it's not how they've been their whole life. This is a really big new change. They're changing their sleep patterns. This is when they start having issues where they may have loss of bowels or bladder. They need a lot more personal care help. So this stage, you can, oftentimes is a lot more alarming. You can see, like, we need help, something's going on. And then the end stage, this is typically where we come in as hospice support. So this is when they're really not able to communicate. They're having issues with swallowing, which a lot of times one of the biggest reasons, one of the biggest causes of death for folks with Alzheimer's is due to aspiration pneumonia. So they're not able to swallow correctly. That food gets stuck somewhere in their lungs, and they have aspiration pneumonia and pass away from that. They're going to need round-the-clock assistance. And they, a lot of times, revert. This is where their reality is maybe in 1957 when they were in high school on the cheerleading squad. So their reality is somewhere very different from our reality, which is important, again, to understand that. So what to do? And this is what I always say. How do I do this?
Middle button.
No, did I turn it off?
There, you got him back.
Middle button. Okay. You must meet them where they are at.
Correct.
And do you agree?
Yeah.
Because if you want them to meet you where you're at, you are guaranteed to have behavioral problems. It is not going to work. You have to meet them where they're at. And I always think about when we start seeing behaviors, this really simple chart from my Psychology 101 days, and this is called Maslow's hierarchy of needs. And it's really basic human needs. Murray's laughing at me because he says this is outdated, but I still like it.
You're stuck in the past.
Yeah,
57.
I'm getting haggled here. Okay, so the main one that I think about, and I'll give you an example after this, is the physiological need. So when you're looking at somebody who's demonstrating behaviors, you have to start right here. Does this person have adequate air? Are they short of breath? Do they have adequate water? Do they have adequate food, shelter? sleep, clothing. We don't need to talk about the reproduction. I guess that's probably not applicable. But that's where you need to start. When you're starting, you have to put your investigator's hat on. You need to start at what are their basic needs. Are those being met? And maybe, hey, they haven't had a sip of water in 6 hours. Get them some water. That could solve the problem. You can also look up here at the safety needs. Are they, what are the safety issues around them? So I'll give you an example I think I have on the next slide. Oh, I'm gonna go to this one, case example. So this is something that I experienced working with a lady who I love. She was 84 years old with Alzheimer's. She was really happy. She was very pleasantly confused, we say. And then all of a sudden, like just one day out of nowhere, her behavior drastically changed. She was, angry, and you try to go near and she's punching and she's growling, and it's like, wait a second. So I always say you have to put on your Sherlock Holmes hat. What happened? So I had to stop and say, okay, has she, her needs being met? Has she eaten? Did she have sleep? Did she have water? Basic needs. And then I started thinking, okay, what changed? And now that I'm saying it, I'm thinking maybe this isn't appropriate, but of course the men here understand that women wear brasiers. And so after some investigation, I figured out that her daughter brought her a new brassiere. That brassiere had underwire. So every day we were putting this on her, and that underwire was stabbing her. And she didn't know how to communicate that. So what do? If you can't communicate, you act out. So it was something that's a really simple example, I guess, for me, because I've had experience. But if somebody hasn't had experience with behaviors, it's hard to step back and say, let's start from square one. What could be the issue? Okay, number 2, safety, number 3, and then kind of problem solve through it.
Correct. And with your example here, if I was looking at the patient, my first instinct is, well, this patient, they can no longer articulate their needs.
Mm-hmm.
And I've always said that an Alzheimer's patient is going to revert back to an infant. Just like if you had children and you were raising your children, how a child would be getting our attention is they usually act out because they're not verbal.
Mm-hmm.
They know they're in pain. If you've ever taken care of a baby, you know that you've got to soothe that baby. You got to figure that, those things out because they're just incapable of telling you, what's going on. They know how to lash out. And the only way they're going to get your attention is for them to be hitting you, scratching you, yelling, screaming, crying.
My nephew Lucas has started to bite, I hear.
and Lucas has attention.
Exactly.
Try to figure out what is going on with Lucas or with in this situation.
Exactly.
That's very common, behavior for an Alzheimer, for a dementia patient that has just progressed. Is there the ability for them to articulate what they're doing and how you can help them, because they're not going to be able to tell you what's wrong.
No. So another just basic question is for the caregivers out there is, what do you know about this client? Do you know what their history is? So, I always think about, a lot of this cohort, they grew up in an era, a culture, Marie, you can talk to a different culture than what we're used to. It was much more private. It was, the rules between male and female were very different. So when you're thinking about these Alzheimer's and dementia folks, a lot of times we say they kind of regress back to infancy or childhood. What was their childhood like? What did they experience? again, had a woman who was from Germany, and she was very, very aggressive, panic attacks when anybody would come near her. So the care home was really upset because they couldn't provide her personal care. They couldn't get her showered. They couldn't get her changed, even her briefs. Well, I had figured out somebody in the family, and come to find out, she was severely sexually abused during her childhood. But we don't know that until you ask. So I think, again, different approach. It was definitely a different approach with her, knowing that she had that abuse. So we're not going to go in there like gangbusters trying to change that brief. Maybe we put in an insert instead. Maybe, maybe we're just putting her on a chuck instead. So again, trying to minimize that re-trauma, because that's trauma that she's living in. Again, she doesn't know how to articulate it. She doesn't know that she's experiencing that necessarily. The other thing I always think of, and it drives me crazy, is I oftentimes go into assisted living homes, and I'm going to use you as a dummy. This is how the caregivers, they walk up. Okay, Mrs. Smith, we're going to the shower.
And I'm like, get the hell away from me.
If you did that to me, I would punch you too. And so a lot of people get upset with that. But again, we're talking about a cohort that was very modest, very private. So when you have a male caregiver approaching a female who is basically trying to take their pants down to give them personal care, that's not going to work. You got to find different approaches to that. The females are very different in their need for personal care. It's
we generally start with, so if it's a male staff working with a female, we just, keep the female until they become more comfortable to the team there, the male team, or the female or male, whatever it be, is just bathe them in their clothing.
Mm-hmm.
So they can get in fully dressed, mm-hmm. and you just clean as if they were naked.
Yep.
Same way. Eventually they will get accustomed to me, the male caregiver, showering them completely nude. And the reality is, it is not so much important that they be showered every day or every other day. As long as the peri area is really kept clean, they're going to be okay. Mm-hmm. They really are. Most of these folks didn't take a shower or a bath but once a week, mm-hmm. Because of their age. And they did it in the living room and bathtub, that type of thing. So when you look at the whole scenario, which Bronna has been talking about the way that they were raised, most of these folks were sharing the same bath water, once a week, and they all did it, and some parents did it to their children right in the living room. Mm-hmm. So they are used to that. But I think the easiest way to get around this is if you just bathe your resident or the patient in their clothing, and they'll come out, they'll disrobe themselves, there's your towel, and they're going to be okay. And they will get used to it.
Yeah, and I think that's like the name of the game is pick your battles. I mean, what are your goals? Like Anthony said, we definitely want to prevent infection. So it's important if somebody's being combative, if we can get one thing out of that interaction, what's the most important? Choose your battles. And then we have techniques too, and Anthony is going to talk more about these. So techniques for if somebody is having behavior. So we do a lot of distraction. So somebody all of a sudden you can see them getting kind of reared up, riled up. Well, hey, look at this picture, Anthony, or write, here's something to write, or put on some favorite music. Art. be,
The approach with someone, and what I specialize in the actual patient that is really out of control. So these are the residents that I take care of are really residents that are being discharged from a facility, from large, centers to the assisted living home. But one thing that I've learned is these individuals need to be heard. That's all they need. When you approach them, if your tone is just very soft with them, they're going to respond, to you. When you're giving them and speaking to them directly and more of an authority, that's where you're going to get yourself injured and they're going to get hurt. All they want, is they want to feel safe. If you're calm in a tone and a voice with them while they are off the wall, they're going to calm down. They just need to know that they're loved and that they're safe and they're not there to hurt them. That's their greatest fear, is they're going to be hurt. When they're talking with their conversations that they're having that are just really just off the wall or off the chain, I like to say. You're not going to argue with them. You're going to go with that conversation. You, in fact, you are in their world. You've got to put yourself into their world, and whatever is going on there, you need to be a part of that world. But offering a lot of things for them to do that are high maintenance activities for them, because chances are their attention span is going to be very limited to 3 to 4 minutes. Or I find that with the population that I work with.
mm-hmm.
There's obviously different behaviors out there, but giving them, with like art projects, they've got to be instant gratification with their art. It can't be projects that are going to take them an hour to do or half hour to do. It's got to be instant. And just like a child, they want that instant gratification. With animals, one of the greatest things that I have learned with animals, I used to be very OCD, and I would never have a dog, a chicken, never have a cat, never have nothing in my business. But one of the greatest things that I've learned was a rabbit, because a rabbit is so calm. In my situation, my residents wanted rabbits, so I got them 5 female rabbits. After 30 days of them, really just loving on those rabbits and how calm the rabbits are, they decided they wanted to start breeding rabbits. So I got them male rabbits. So we have rabbits, everywhere now, but, giving them ownership,
Mm-hmm.
it distracts them because they have a project of raising and breeding rabbits. Mind you, of course, they have no idea how to do it, but, in their mind, it's a good thing for them.
Mm-hmm.
It keeps them calm, and that rabbit just is so calm and soothing, and the touch of that rabbit. So animals are good. You've got to be careful with the animals too, because you don't want an animal that is too active for it. What you're trying to do is keep the setting that resident is in calm. And so that animal will help calm that resident down for you. Redirection is just a constant. It is so much easier to redirect a patient rather than administering a psychotropic drug for that resident. That'll just cause you, more harm for them and yourself, because now you've got to be worrying so much about the fall. There is a time and a place to use the medication, and yes, sometimes it's necessary, but the redirection on the resident that is wandering is telling you that they, that they've got to have something to do.
Do you know if it's true that, I just heard this yesterday, that there are some places that put black dots in front of patient's door, like thresholds, because they think it's bugs, and for wanderers, they put those there so that they don't venture out of their rooms and they don't run across the bugs. Have you heard of that?
I haven't heard that, but it would be the same concept of what you see in putting a, like a mural in front of the front door of a bookshelf so that they won't, an exit seeker won't go up to the door because there's no door there, even though there is a door, but just something to disguise, you know, front door or back door. So I'm sure that's probably the same, you know, level as what you're talking
I
about.
thought it was something a little, like, I just want to make sure people are using it for good, like, at the front door and back door, I don't want people in that room.
Yeah,
Right.
yeah, and I think that is, again, something that I can say, Anthony has designed his house so that he has safe spaces for his folks to wander. Again, the last thing you want to do is try to restrain them and keep them from doing that. So Anthony has this, like Anthony's playground, where it's this safe area that they can go, they can touch things, they can interact with the environment. There's plants, there's water, there's music, there's water stations, there's all this tactile stuff for them to kind of keep them moving, which is so successful.
It is, you know, again, offering a lot of the activities that are self-stimulating without going overboard. You know, you can't have too many activities going at one time.
That's another thing I really like about Anthony's is, it's proven that, you know, folks with Alzheimer's dementia, they need a routine. It's not okay to just start throwing different things at them. Anthony has a very scheduled routine, and the residents know it. And so that really helps to keep them feeling safe.
It does.
One of the other things you have with safety is stress. We don't think about the stress that folks with dementia of any form have because it's not making sense, things aren't there. And so one of the reasons that people wander sometimes is also stress relief, because the body knows one of the first ways to relieve stress is movement. And so that's another thing to keep in mind when you're dealing with that some of that movement, and that's why the chair exercises and some of those things can be very helpful, because it helps to burn off that stress.
Yeah.
Do you have more on the slides?
I don't know. Let me do this clicker. I think, again, redirection, that just makes me think of another example I had. We had a gentleman who, again, kind of regressed. And I believe there's such a thing as muscle memory. And this gentleman, you know, got up at the same time at 5 o'clock every day. He owned his own business. He was very, you know, very proud of that. And so he's regressed to that age where he is a young business owner. And he would wake up and, where's my keys? I'm late for work. I gotta go to work. Where's my keys? Where's my keys? Where's my keys? And the staff kept saying, you don't have to go to work. This is your home. And he was going berserk. No, I have to go to work. It's my company. And so I found, you know, some random keys and gave him a set of keys. And he, you know, in the morning he'd get up, where's my keys? Where's my keys? Here's your keys. You have to go find your wallet. And so he would go on a little, you know, test, and it would make him feel better just to have his keys, to have his wallet. And then, you know, the redirection, and he would turn it around. But, you know, those patterns happen. And sometimes the easiest thing to do is give them what they want.
Yeah.
Oh, that's it. Okay, so we really wanted to take time to answer any questions, because I know a lot of caregivers, a lot of people experience this and don't know what to do. So if anybody has any thoughts, questions.
What is, so for us, we have a nurse practitioner and a clinical psychologist that does education for our facilities on how to de-escalate situations that occur like that. But we don't do it for every building. So what's a way that I can explain to facilities, because we get, hey, we need some lorazepam, or we need something, he needs a PRN because he's crazy. But really the opportunity that we have there is teach them non-pharmacological ways to handle the de-escalation, redirection, all that. What's, I guess, good tips to tell staff on how to handle, like if you were to put it in like a little snapshot and give them a 30-second, if you will, what's your best advice for the staff?
The activity that, that is being presented to that patient,
Okay.
And actually just that one-on-one, just sit down and look.
I think too, again, if you ever watched Anthony with his residents, and you can tell he's very slow. He has short, he is.
Well, I would.
He's slow, he's intentional. He talks to them in short, directed tasks. We're doing this. He will approach them slowly, and I've seen where, there's a woman who's agitated. Anthony will say, I'm gonna take your arm, and we're gonna go, and we're gonna get to the bathroom, and he's very slow. His voice is calming. He's not rushing them. He's not forcing them, and he's talking to them in short sentences the whole entire time. Okay, now we're gonna do this. And now we're gonna do this. And
what do we do with the crisis of short staff? So people who don't have the time to do what we know it to be the right thing. What if it's just not a possibility?
Mm-hmm.
What if they can't be slow or sit down and have a one-on-one with them because they're passing out medication to 16 other, residents, and
maybe they shouldn't have those patients.
I agree, but I can't like scoop them up and take them away.
No, I have always found that just, even today, we have very difficult, patients that are in the home. It's just to attach the patient with you and have them follow along, with really.
Yeah, Anthony, if you go to his house, he's usually got one person kind of in tow with him. Come with me, we're gonna go do our paperwork, we gotta go do this. So again, he's engaging them.
Because I will take, I will pull out a patient that is very, being very aggressive, and the team members having to deal with that with the other residents. Well, I'll just go and get that resident myself and bring them into my office and give them a task of, have them play with the coffee machine, make me coffee, whatever, just give them some kind of job. It's just, you just got to find, and you've got to research really that patient to find out what their real needs are. You're going to have the patient that doesn't want to be touched, and doesn't want to be bothered, doesn't want to do activities, and that's okay. That's okay. Like I said, the showers isn't that really that important. That they don't take showers.
My wish would be to have, again, like a stand-up for any new patient that comes into an assisted living home. Maybe even like a one-page sheet. This is Mrs. Smith. She's from Texas. She grew up on a farm. We can do a lot of redirection through ice cream and sweets. Would you agree? Chocolate. She loves chocolate. Okay, there's something I can put in my toolbox. Oh, she grew up on the farm. What if I show a picture of the chickens or the cows? There's something for my toolbox to maybe if I need to distract her. She had 3 children. Oh, can you tell me about your kids? And maybe they don't know, but it'll it engages them, and it redirects, it distracts.
But getting that information, is generally in the service plan. If the resident is in a facility, they would have a service plan, and there's a whole page that is asking for that information from the family.
But legitimately, in the bigger, so Anthony is lucky he has a smaller 10-bed. In those big facilities, that would be like, how do you get that information out? Because the caregivers aren't all looking at those care plans on every new resident. I wish they had to, but.
One of the other things for your people that are short-staffed and they're trying to do too many things, projected energy that I'm in a hurry, I'm rushing behind, and I'm chaotic, that projects to people. And when Brianna and Anthony are talking about slowing down, if you slow down, you are more productive than if you're rushing around chaotic. So one of the things to teach your people is, I know you're short-staffed, I know you're busy, I know you're gonna get all these things done, but try to breathe and move at a steady pace. And the reality is you will get done more than if you're rushing chaotic. And what you're projecting, the energy and the spirits that you're projecting out into the place is much more calming and much more gentle for those folks, and will tend to be just a technique that's easy to do. The difference between reaching for something and reaching for something.
Mhm.
And just if you can teach your people, especially when they feel that they're up against it, to breathe. One of the great things to teach them is breathing techniques. And breathing techniques, most people don't breathe right. They only breathe with a third of their lungs, and especially if they're in a hurry, they start breathing choppy, and that leads to less brain food with oxygen, and we tend to react differently because we're stressed. So if you can just say, take a breath, move at a nice steady pace, it's going to project calm to those around you, and they're actually going to accomplish more.
Go ahead.
I was gonna echo what she said, it's a great comment. So my situation is, I'm a doctor, and I get calls from the nurse who's getting bothered by an institution, who's bothered by the patient. And so by the time it gets to me, at time, I don't have 30 minutes to go to the source and say, what's been going on, and so the reality is, this is great, but the reality is what you're experiencing, what I'm experiencing is, we need a psychotrope. She's wild, the facility, and there's other subtle pressures in here. I want to keep the facility happy for this business, not necessarily yours, but you know what I mean with Brianna, because you're a business man, you understand.
Yeah.
There's these layers as a doc. If I say,
Yeah.
well, I want you to use non-pharmacologic options to calm the patient. I know all this. I'm not saying I know, but sometimes I explore it with a nurse, sometimes I don't.
Yeah.
Like, yeah, well.
The system is really.
I don't really have a question, I don't really have an answer, I'm just like,
Yeah.
I'm in this space, I'm similarly frustrated for them
Mhm.
and for my own limitations, because by the time they're calling the MD, you know what they want. They want a trial, they want my advice.
Maybe if like what we would do is a PRN for now, but education for the future.
I did my first question is, did you see the patient?
Yeah.
Yeah.
The nurse didn't go and see them, they didn't really upset.
Mhm.
They just took a message and then they came in the trial.
Yeah.
But
The reality is, though, for assisted living, whether it's the large center or even, the assisted living home, if the patient is beyond their scope of care,
Yeah.
they need to discharge.
Mhm.
That's the bottom line.
Yeah.
So if they can't meet the need, they need to discharge. And obviously, a corporation is there, to generate a large volume of income. So it's easier for a corporation to get the psychotrope,
Mhm.
to retain the client.
Yeah.
Well, I think that's right, because working with patients and then for different, homes and assisted living, it's very different. But I think the one thing in common that's the problem is, that's been going around, I've noticed that, I'm not in the position to say anything, right? Is, they admit residents or patients that out of, the scope of practice. So you end up calling doctors, oh, I need this because but to begin with, whoever did the assessment, they're not supposed to be in that, setting. That, you're already short of staff, this person needs more help, and they're stuck there. And then, you're stressing out the care staff and then the doctors, because you want them under control. So the tendency is you're over drugging the patient, which tends to fall more often, like that there's no quality of life. And, that's just the reality. So like, sometimes it's frustrating, let's just watch it, because like, a lot of the people that made that decision that this person needs to live here doesn't actually work with them on the field.
Yeah.
So they don't see the patient, they don't get attached to the people, so you get drained, frustrated, because you really want to spend time to this patient, but you don't really have time, because you have like 65 other patients to deal with, like,
That's a great point.
I think that's just the reality. But like, for me, like, because like, you have to love what you do, you just have to calm down.
Mhm.
And everybody else can actually wait and do what you need to do with this patient. I think that's the best you can do. Because you hurrying up is not gonna help the situation. You just have to, everybody, you just have to stop what you're doing, just calm down, find this resident, and then move to the.
Yep.
I think that's the best you can do. Yeah.
And it's true, it's really hard out there in healthcare right now. Everywhere we go, they're understaffed. I think people are still dealing with the trauma of COVID. And so there's lots of emotions, there's lots of things going on in the world. And I just believe that we need to do better by our folks with the dementia and Alzheimer's, because if you look at that population, the growth of the dementia and Alzheimer's disease is astronomical. I mean, it is mind blowing. So, education is great, and just keep advocating that these facilities, these centers have mandatory training. If you have a new caregiver, you should have mandatory training if you're going to be working with this specialized population. And some of them, they don't. So that's my soapbox for the day.
But I've always been a firm believer, in assisted living homes versus larger facilities, just because of the one-on-one care and the more attention that individual is going to get. I'm also a firm believer in that the way that an individual moves into Roses, I'm not going to change that. If that person is naked at home, they're going to be naked at Roses. They're placed there appropriately. None of them are fearful because Sally is sitting next to Bob and they're both naked in the living room. That is their home. I'm not going to be calling Harmony Hospice if they're under their care to say you need to get your regimen control because they're naked. I'm not going to do that. That's their home. I'm going to give them privacy. I'm going to offer them a sheet at least. If they don't want that, that's okay. It's just easier. Again, choose your damn path.
Yeah.
Choose. So the behaviors that I work with, and I know that Brianna, if she's in my home, what she knows what you're getting. When I call Harmony, they are, most of them are there with a psychiatric diagnosis as well. We've had psychiatric issues that were untreated or are barely beginning to be treated at the age of 74. They have dementia. So it can be quite challenging. I get stressed out. I do it just like my patient. But I've learned quite a bit from them on how to really de-escalate things and how I communicate with you too. A lot is that if I remain calm, I maybe put about to sleep, but it's nice to see everybody relax.
Yeah, no, it feels good. Before Anthony came, I was like, 10 million double. Yeah, that's that energy, Murray. It's the energy. Yeah.
It does. And one of the other problems that caregivers have in facilities, especially if they're understaffed, they do not deal with their own stress and grief issues. And when you carry that, you project it. There's a term that we use all the time. Pain not transformed is transmitted. Whether it's emotional pain, physical pain, from stress, from overwork, and you carry all of the issues from your regular life into your work life. And if you don't take time to center yourself, as we say, and to manage your stress in that, to get yourself under control, you carry that in. And especially for individuals who have behavioral issues, who are in dementia, where they're struggling with the fact that my world doesn't make sense. And it should, and now I don't know, or I need to go to work.
Mhm.
I need to go to work. Well, you're 93, you haven't been working for a long time, but I need to go to work. They're feeling that tension, and if you're tense dealing with them, you just ratcheted it up, and their pain is going to come out. And that pain of being frustrated, being scared, being all of those things is going to come out. The other thing that happens is when caregivers become afraid of the people they're working with, they transmit that fear out,
Yeah.
which exacerbates. That's why we need to train people to calm themselves down.
Well, I think, again, you're talking about stress with caregivers. So we experience that on a daily basis where we go into homes. And God bless all of the husbands trying to take care of their wives at home by themselves, the wives taking care of the husbands, the children taking care of their loved ones. And we so many times see that they try to do it alone. They're not reaching out for help. Maybe they're embarrassed because mom, who is this dainty, very proper woman, all of a sudden wants to take her clothes off. And how can me as a daughter tell, my friend, I need help with my mom, but oh my gosh, she's acting bizarre. So we walk in on a daily basis to these situations where we're seeing blatant caregiver burnout. Caregiver burnout is no joke. So we've had a lot over the years, a lot of our folks who, the husband, let's say, is taking care of the wife, trying to do it by himself. Guess who ends up in the hospital first? The husband. He had a stroke, he had a heart attack. He's so stressed out trying to manage this by himself that he ends up getting sick, or that caregiver ends up physically getting ill. And if the caregiver is physically ill, they're not helping their loved one. So I think that's a big, big issue out in the community too, is recognizing and preventing caregiver burnout.
I think the hope is that when you are working with somebody with Alzheimer's or dementia, that you already know about them, right? You already know some about their history, when they were younger, what they enjoyed doing. Did they play piano? Did they sing? Did they dance? Things like that. And I think those things are very helpful in de-escalating situations, because it's like you were talking about with redirection, right? You can redirect a lot easier if it's something that they're actually connected with, right? So I know, like, when I used to do physical therapy with people with Alzheimer's, dementia, I would try to know going into that situation what their interests were, what their job had been. And then also, sometimes I would use methods like snapping or tapping a rhythm, or, anything that would kind of get their attention and get them off of what they were already perseverating on.
So we have a woman right now who is pretty much bedbound, and when people come in, she just screams. She screams and screams and screams. Tried all these different interventions, and the nurse figured out from family that she loves Elvis Presley.
Mm-hmm.
Nurse goes in, she turns on that Elvis Presley music, and she just, taps, and you can see her eyes, and she's engaged. And I will say, music therapy is one of the most important things that you can do for folks with Alzheimer's and dementia, because that part of their brain, it's one of the last parts of your brain that's affected. So you can still touch people so deeply through music. So if you can find out, hey, I had a woman who I loved, and I would go to the home and she'd be panicking, wandering, and I would gently come and say, Joan, come walk with me. And we'd start singing, You Are My Sunshine. And she would just smile and we'd walk and it was beautiful. But as soon as I stopped that, she was, oh. So again, if you need help, I would say music is an amazing thing that reaches a part of our brain that is, I don't
It cuts through all the filters.
yeah,
It does.
cuts through the filters. Yeah, I like that.
I know when I do karaoke with memory care residents, they do light up.
Yeah.
They connect. They start singing song lyrics, and they may not even be very verbal.
Family.
That's what,
So
that's
it's
what's crazy.
amazing.
We just had Nellie, my pony, out at one of the memory care units, and a woman was walking down the hall, and you could tell, kind of agitated, didn't know where she was at. And I brought my pony through, and she stopped, and I said, "This is Nellie." And she just kind of looked at me, and I said, "Her name's Nellie." And she came up with this song.
Until the sun shines, Nelly.
Wait, and the people that the staff there were like, she started singing this song, this old tune of Wait Till the Sun Shines, Nelly.
Yep.
And that like the director just jaw dropped because this woman doesn't communicate, but she remembered that music. It was so powerful.
The other thing is, remember that if somebody is in their 70s, playing music from the 1930s really doesn't relate. Remember, they weren't born
Right.
until the 1950s. So one of the things I'm pleased to see in care facilities now is the music has moved forward. For years, we had people going into care facilities and they were playing music from the 20s and the 30s that, yes, maybe they do, but really wasn't their music.
Yeah.
Now they're moving forward to music that is of the era that people know, because that's what you relate to.
Justin Bieber overhead when we're retired.
I
Yeah.
know.
Yeah, well, we used to laugh about the fact.
I'm gonna have salt and
that-
pepper.
Yeah, we used to laugh about the fact when I was young and started out, that when we were all in a rest home, they wouldn't be playing, well, they would be playing the Beatles then, as opposed to playing some from the 1920s, that kind of music, which some of us knew, but that's not our music. They would be playing the stuff from the music. So I like it when I go into facilities now, they're playing my music.
That's a sign.
Yeah, it's the sign that I know where I am. But it's, make sure that, and the other thing is, if you can find out from the family what their music was. Because there are people for whom rock music is an
Oh
athlete.
yeah.
That's right.
Mhm.
Oh yeah.
But if they're into Wagner, you put on the ring cycle, they're in heaven.
Mhm.
But or a country, don't think that everybody in their 80s likes country and western music.
So, good point. I'm really happy that everybody came and we had that discussion, and just want to, again, tell people that we're available to go do education. We love to present to people and help them to understand how to better care for folks with this disease. Again, Atlas Medical also does that. So there's a lot of resources out there that people can use to, again, gain confidence in their caregiving, gain some, maybe just having somebody to talk to, and Anthony saying, wow, well, you know what, that happens a lot. Just being validated that these things that they're seeing with their loved ones, it's not them, it's not personal, it's the disease. So we would challenge you all to get out there, and if you see that, ask if they'd be interested in some education. We'd love to do it.
Thank you.
Do any of the people attending via Zoom have any questions? No?
Okay. Thank you,
Okay.
Angie.
Thank you.
Anthony, do you have anybody at home currently? Don't take it.